respected chairpersons and my dear friends, a warm good afternoon to all of you. You know, the speakers before the lunch and after the lunch has got a tough job. The speaker before the lunch is standing between you and the lunch, and speakers after the lunch is standing between a wild dream and some lectures, because there is an elementary hyperglycemia and a cerebral hypoglycemia. Whatever said and done, the topic of today is of importance. Thank you, organizers, for this wonderful conference, and we give an opportunity for all of us to meet and learn from each other. And when you talk about clinical safety of patients, I think the sky is the limit. All of you agree that we need to have some robust system. Rapid response system or rapid response team will help us to raise the bar. At least we can reach to the next level of patient safety. Now, these are programs by definition designed to improve the safety of hospitalized patients whose condition is deteriorating rapidly. There are a lot of components, which includes a prospective identification of a high-risk patient. Number two, there is an early notification to a team which is pre-selected and trained. And there is a rapid intervention by the response team. They have to be capable enough, and we need to evaluate the performances very clearly. A lot of terms have been used in the literature. Some hospitals, most of you have that system in place. Rapid response team, which might be nurse-led, or a medical emergency team, which may be physician-led, or it's a critical care outreach team. Quickly, the difference between a cardiac arrest or a code blue, some hospital call us, and a rapid response team is that the code blue team or a cardiac arrest team comes into picture when the event has already happened, be it a cardiac arrest or a respiratory arrest. Whereas the rapid response team, the role is very pivotal in averting this event, so they come much, much before the terminal or the final event. Now, this is a term which is sound interesting. If you see a patient in the floor or deteriorating slowly or rapidly, he or she shows some abnormalities. And if the team in the floor on the ground level fail to react promptly or fail to escalate care, that will end up in what is called as failure to rescue. And failure to rescue end up in serious adverse events, which has got severe disability and death. If you look at the epidemiology of serious adverse events, every patient will give a warning sign. And that warning sign is something which we need to pick up, improve your quality improvement to pick up that warning sign, which avoid a major catastrophic event. Similarly, failure to monitor. You know, the monitoring system is not very robust in the floors or the rooms. We can't afford to have it by whatever standards we talk about. The intervals are limited, the manpower limitations is there. Even if you pick up something, even if you monitor and pick up something, the failure to escalate is another challenge. Because the system of hierarchy sometimes call one person, call another person, and then this is a wasting time which end up in a disaster for the patient. So the point is that what are the principles underlying rapid response system? The deficiencies in identifying and responding a patient in crisis is a rationale for RRT system. Standards, JCI standards previously mentioned that every institution should have a suitable method to make the patient condition identified before it gets worsened. And rapid response system addresses this goal. It is to identify the patient at risk, communicate change in patient status to ICU so that we can shift the patient early and avoid a delay in patient transfer, which will avoid a disaster catastrophic event, and they are also equipped in providing effective and timely intervention. If you ask me what are the components of a rapid response system, afferent limb holds good because this is a person on the floor. The criteria for calling RRT, every hospital has got system in place, or we have available systems called as MUSE, Modified Early Warning Signs, which can be picked up and can be used to activate the system. And the personnel will be the bedside nurse who trigger the system. And once it is triggered, the team has to come in very fast. So the traditional system is bypassed so that the acute care has been activated right at the bedside. How much ever you keep the MUSE or warning signs in place, if the staff feels the patient is not right, that should be an objective criteria to call a rapid response team. Our hospital has got a policy called as Code Purple, or they have a direct phone number called as a *659, and which the physiological parameters worsening could be a cardiac, respiratory, or anything which every hospital will have them. And the MUSE, Modified Early Warnings Call, is incorporated into the system. The efferent limb is the second part, where the RRT team comes inside and give the timely intervention, bedside management to shift the patient to the ICU. The third is also important because we need to know how to improve the quality when each time. The composition of the rapid response team can be tailored to each institution. It can be same or different for the arrest. Either mostly it is a nurse-led system, and the comparative data between MET and the RRT, where the physician-led team and the rapid response team, there's not much of a difference because this is to trigger the treatment initially and come back to it. What about the disadvantage? Yes, every system has got its own flaws. Keeping a system can de-skill the ward nurses. The ward nurses can feel that I can rely upon RRT team to call for everything. It can also affect the resources. You're taking out the senior-most nurses or whatever team from the pool and making them additional responsibilities. And sometimes the implementation can be a question mark in getting your triage system may not be good. You shift the patient to a room, he get deteriorated and come to the ICU. So that is a drawbacks. Whatever said and done, policies are there, but when you look at the larger interest, it will be much of a benefit. Now, the literature support evidences in multiple journals is not very supportive of them. Some journals say that the creation of RRT has decreased the number of cardiac arrest and patient outcome, whereas one of the randomized studies has shown that it has increased the calls and the response system. However, when it comes to the outcome measures, it may not be good. But all these trials are based on different patient population, and some bias will happen here and there. Now, I would like to put across what our experience in our hospital called as the Rajagiri Rapid Response Team. We implemented it in 2016. It's a 4-member nursing team from the medical ICU. 4 people have been taken out, and they have been given extra training with regards to resuscitation measures, ACLS and BLS. And they have been introduced to some skills which they need to be identify and treat the patient on the floor also. They are governed by the nursing and the Department of Critical Care Medicine. Now, the key features is their 4-member team, 1 person on call round the clock. They're based in the ICU, always available. They're on-site and accessible. And they have critical care skills to identify, to treat at the bedside, and they're authorized to consult the intensivist on call and shift the patient to ICU if they think the patient requires ICU care. They're the part of the code purple, which we call for the patient deterioration. They're also the part of the code blue team. And a couple of quality improvement is that they were given additional responsibilities to do a scheduled rounds in the tracheostomy areas, and the patient was shifted out of the ICU to prevent an event happening or good monitoring. They also help in transportation of the patients. And moving forward, when the difficult procedures like a cannulation is not getting easy, nurses do call them because that's another important area where they can get a lot of patient satisfaction. Sampling is another area, difficult sampling, they can also sort of help. And end-of-life care support. Even if the DNA, DNR forms are signed with whatever hospital policy you have, presence of a senior-most people, you can talk to them about the resuscitation, about the support measures can definitely an added advantage in getting the patient satisfaction right. And now, moving forward, how do you analyze their performances? It is important that you analyze the performances and get the programs improved day by day. We have a team called as CAT. CAT means Code Purple Cardiac Arrest Analysis Team. 3-member team from 3 specialties, which is intensive care medicine, anesthesiology, and emergency medicine. So the RRT, the WhatsApp group, that's something which all of us know that we can get information fast. They report the daily events in the WhatsApp group. Any major issues, major drawbacks will be cleared in 24 hours. Debriefing sections has been done with them and the site of the patient deterioration, and corrective measures have been taken almost in every daily or at least in a weekly basis. And we have a quarterly meeting which is being chaired by the medical director, nursing director, and the quality team. They give their inputs, and safety programs and quality improvement is being done with discussion in that team. Our data. The Code Purple data in 2021. We have around 169 Code Purple activated in 2021. Of this, 13 deteriorated to Code Blue. Of the 159, 156 Code Blue has been averted because 13 were the one we deteriorated to Code Blue. So could have been a implication of averting Code Blue in 156 of the code, 169. And of the 13 Code Blue which has been averted, because RRT was on-site, 10 achieved ROIC and ultimate result in a reasonable patient outcome. This is recent data which I would like to put forward. You can see that the number of Code Purple has been increasing over the last 4 months because, India nurses have been traveling abroad for the last year because everything is opened up right now. So that's okay. We get a lot of corporate calls, but if you can pick up a sick patient and improve the patient outcome, that matters a lot. So even though there are 30 calls for corporate in February, only 20 converted into ICU, rest of things has been stabilized, which definitely is a good can result in patient outcome. Now we expanded our services to what I call it as critical care outreach. This is something based on the philosophy that, RRT holds good. It has been reasonably established. However, unless you train the nurses in the bedside to pick up things and to act immediately and then call, this won't materialize in a good results. That is why we implicate upon quality improvement programs, training programs for BLS and ACLS, mock drills, and also community training. This is an example of one of the quality improvement program with the rapid response team, where one of our nurses, I think she's sitting here, picked up an issue with the cannulations. We found that the number of cannula used were much more than 1 or 2, and number of pricks were around 4. So we put up a matrix which includes the RRT as a center point of helping the nurses in training and implementing the process, which ultimately ended up in reducing the number of pricks and number of cannula used. Similarly, another initiative what you have taken is called as the end up in Rajagiri Academy of Advanced Life Support. This is purely because our hospitals, one of the DNA is academics and teaching. So we embark upon a journey to teach mainly in hospital training across the hospital for BLS so that deterioration is picked up earlier. Again, 3 departments, clinical departments, pool the picture of doctors with the help from the human resources and nursing. And RRT members has been taken as a pivotal role. More than that, when they teach, they learn more. And when they teach, they can implement the same thing in the patient bedside because keep on repeating makes you more perfect. We extended to the community also. The philosophy behind it is that cardiac arrest can happen anywhere. Something happens to any one of us sitting in the room in a community where nobody is there to know the bystander CPR, the outcome is going to be bad, whether I'm an intensivist or an anesthetist or whoever it is. So the community training is important. Based on that, we embark upon a journey to spread the news of resuscitation at the bystander level CPR. We are almost 50 institutions and societies have been covered, and almost 3,000 numbers, external numbers, has been trained till now since the inception in 2018. And these are the few organizations of this. The most important thing is you can see at the corner the Road Safety Advocacy Program. This is a program combined by the Motor Vehicles Department and the Police Department. The taxi drivers, the lorry drivers, the truck drivers has been given training in BLS program. The message is that they can help by doing a bystander CPR if something comes into the picture. Similarly, in the Cochin International Airport, we have a training program with the entire staff, which also is an ongoing process. So teaching is learning is something philosophy which takes it forward, and RRT team with their expertise in patient crisis management has been a pivotal role in this. We move forward. ORRT is another concept which Kerala State has adopted. This all happened with one sick patient in our labor room. Dr. Paili was there yesterday talking about maternal mortality rate. So when he witnessed a sick patient of an amniotic fluid embolism being resuscitated by our RRT, subsequently called the medical team, and ultimately the patient, despite getting into ventilator, coagulopathy, or whatever complications he called it as amniotic fluid embolism, we were able to discharge a mother and a baby home. So that triggered in his mind, and we had a discussion, brainstorming section, and that ended up in creating what is called as an obstetric rapid response team since January 2019. Government of Kerala has taken up the project well, and we have a curriculum and a reference guide in place. We covered 18 training programs in all districts of Kerala. We traveled on a Sunday and took classes, and 1256 doctors were trained in that. So my dear friends, the system of implementation, when you talk about patient safety, innovation is the key sometimes, and all of you must have had innovation. So the rapid response systems are there to save patients and eventually improve hospital quality and care, patient safety. It also can help in decrease the number of cardiorespiratory arrests in the outside the critical areas. It can increase patient, family, and staff satisfaction. Staff satisfaction, again, is important. They know that somebody is there to help them out. Decrease hospital mortality rate, and critical care outreach is something which it can benefit hospitals and the community. That's our commitment towards the society. So to conclude, rapid response systems foster a patient-focused and safety-conscious hospital environment. So my dear friends, I'm joined by our executive director and the rapid response team people who was, the photos just got skipped, and the medical director and our nursing director. Thank you for giving me this opportunity. Let the conference move forward, and I hope all of you had a good time in Kochi.
I got the question. I think for the audience who haven't heard sir's question, what he's asking is that when you give training, is it, consistency is the key. So once you give the training, they might forget about the training. Very true. That is what, so sometimes you have to make some rules very strict. So, the accreditation helps us in making these rules very strict. When talking about hospitals and non-hospital hospital things, when they go for a quality accreditation program, one of the important thing is that they need to get the training correct. That is a one point which they come back to us for repeating the training. Hospital trainings are mandatory. The options are not there. The staff or the in hospital I'm talking about, the staff are given the mandate that you need to get trained and you need to pass the mock drills which is happening in between. If the mock drill is failed in one unit, definitely you'll call them back for a training again. Or if any of the code purple situation, if they miss something which we felt that the team, the RRT replied to us saying that what are the drawbacks in that, which we can easily identify that are they missing in some important basic steps, we'll give the training. Out of hospital training, it is purely, accreditation things. When they comes, they'll come back to us. But we do have the advocacy program, all the programs mentioned, it is repeating every year. This is the third year we are running it, sir.
Thank you, Dr. Jacob.